Let's move on from the concept of mobility and immobility to looking at what we as nurses will be assessing or watching for, and what we'll be doing to and for our patients to help address their mobility issues. What you'll find in Foundations is that we will tell you what to assess on a patient, but not the how-to piece of that. You'll get that information in a health assessment class, so be sure to look at your assessment text for further information. When we start talking about assessing a patient's mobility, we need to consider how easily or not that the patient moves and what does their gait look like as they walk. We'll also consider the alignment of their body. Are the shoulders and hips even? Is there any tilt to the head? How are their arms hanging at their side? Are their toes pointed straight ahead? Next up, we'll look at the joints, their structure, and their function. Are there any swelling or pain in the joints? Do they move freely and easily? Another area to look at will be the muscles. What is the muscle mass? Is there any wasting or atrophy of the muscles? And what is the overall tone of the muscles? Are they strong, weak, etc.? We'll also need to consider the patient's endurance as well. How well is activity tolerated by that patient? Are they getting winded just sitting up at the side of the bed? Or can they walk 25 feet? Or can they walk 100 yards? And they're tolerating it very well. That's some things we'll have to look at. Now that's very general, as you'll learn more in lab, but it'll get you started. When you start working with your first patient with mobility issues, you will develop goals or things that you and the patient want to accomplish. One of those will be to maintain or regain any changes to their body alignment and stability. Maybe decrease any changes to the skin and musculoskeletal system due to the lack of mobility. And ideally, we want to return them to full or optimal range of motion. And if that isn't possible, to prevent complications such as contractures. Remember that sometimes we need to keep them from getting worse, but we can't help them get better either. I mentioned on the previous slide the general things that we assess, and you will also need to learn how to write those assessments in a way that others will understand. So when I said that we would look at the joints, that is referred to as range of motion, or ROM. Can their arms raise completely over their head? Can they bend their knee fully? That's range of motion. It would be written in your care plans as assess ROM capability. I mentioned muscle tone and strength. That is written as assess muscle tone and mass. More assessments are written out for you below, so be sure to read them over carefully. These will be included in your clinical paperwork, so this PowerPoint is a potential source for you to use when you're developing your clinical paperwork, as will be the Ackley Nursing Diagnosis book. Following an assessment, a nurse is going to determine the course of action that needs to be taken with the patient. It will be mentioned many times this semester. Be sure to include the patient and the family when determining this course of action. The more common interventions for immobility issues are included here. It will be critical to move them or change position at least every 2 hours when in bed. This could be just subtle changes, putting a pillow behind their back, between their knees, changing them from side to side. Each patient's different, so it may be more frequent than every 2 hours. Usually the plan of care for the patient says turn Q or every 2 hours and PRN, which means as needed. When a patient is in a wheelchair, they will need to be encouraged to shift their weight every 15 minutes. If they're not capable of remembering that, that's where special pads and bed type devices come in, whether it's a patient that's in bed or in a wheelchair. Besides turning and shifting weight, Active or passive range of motion is going to be done 2 to 3 times a day. Now, active means that the patient can do it totally on their own. Passive means that staff are moving the patient's extremities for them. We always encourage them to move on their own, but some patients can't move, so we need to do it. An excellent time for range of motion is while doing the activities of daily living, such as bathing, eating, grooming, and dressing. Combing hair and brushing teeth is range of motion, as is getting dressed, putting on pants, putting your arm through a sleeve. You can accomplish 2 things at once by doing that, and you always want to save time. Nursing is responsible for the patient, but another necessary team member for patients with mobility issues will be physical and occupational therapy. It may be necessary for nursing to advocate for the patient so that they do receive quality therapy from these other departments. It may be that we need to advocate with the physician to get physical therapy or occupational therapy assigned. Again, nursing is responsible. We will be helping the patient or the client to ambulate, as well as PT and OT doing the same thing. It's not exclusively one department or another. You should have learned about assistive devices in lab. Be sure to review those and how to properly do canes and crutches and walkers. Please take a minute and note that the interventions below are written for you as they would be in the patient's plan of care. Be sure to refer to those when you're writing your plan of care for clinical paperwork. Now, besides the physiological component that we've just discussed, remember, we're going to need to do an assessment for the psychosocial piece as well. So the mental, cultural, spiritual, all of that goes under psychosocial. Any patient with mobility issues may have difficulty sleeping or going to sleep at the wrong time. And because they can't move around as easily, they do tend to become isolated, and they will have trouble taking care of themselves. The goals that the nurse and patient frequently decide on will be focused on maintaining or restoring that sleep-wake pattern, helping the patient socialize, and helping the patient become independent in their self-care. Sometimes this is an exercise in tough love because we want to do for them, but we need to encourage them to do for themselves. Now, I've included on the slide the most common assessments we would do that would help you as a nurse achieve those psychosocial goals. Mental and emotional status will be important. Mental is about how alert and cooperative the patient is, while emotional focuses more on the happy, sad, how they're feeling. You will also watch the patient's behavior and their ability to make decisions. Ask yourself, is the behavior appropriate to the situation? How is their decision-making ability? An example of this would be a patient in a rehab setting following hip replacement. The patient says they understand the need to call for assistance, but is attempting to get to the bathroom without calling for help. Why is that happening? Is it emotional? Is it mental? Is it neurological? That's all part of what we're going to have to figure out as part of the assessment. Most of the assessments don't require further explanation, but let me add a few more points for you. Coping is about how they are dealing with the current situation. A loss of mobility that is sudden may result in them struggling with their coping, especially if they don't have good coping skills. Someone who treats everything as a major drama may not cope with the mobility loss well at all. It may be something you'll need to talk with them about. Coping and monitoring their ADLs or activities of daily living may go together. A patient that is struggling with a change in mobility may choose to avoid getting cleaned up and dressed. Coping and family support will also need to be tied in together. Many people use family support and relationships as a means of coping. Now, these assessments can be harder for a novice nurse to do because one person's normal may be someone else's abnormal. Start paying attention to your patients in the coming weeks. You'll learn by watching. Depending on the specific psychosocial problem that is related to mobility, the following interventions may need to be used. When helping with coping, patience is going to be very important, as will the need to be a cheerleader. You may hear yourself say, I know this is hard for you, but you are doing so well. It seems to be getting easier each time you do it. With patients that are isolated or confused, maintaining orientation will be very important. That's why we encourage you to talk with each other and the mannequins right now. Introducing yourself and what you're doing is part of orienting the patient. Schedules help to keep the patient oriented and involved in their care. Depending on the facility that you go to, they may be posted on the door. Schedules might be posted on monitors. Give the patients as much choice or power about their daily care, and that's going to help empower them and boost their confidence in their own abilities. Look over the remainder of interventions that might be used. Remember, nursing is most closely involved with the patient, but it is often necessary to bring other team members, as I've mentioned before, to help those patients that aren't coping well. So please move on to part 3, complications, and what nurses will need to do about those complications.